my journey to robotic TKA. Now, the reason for that is I've been asked to talk about robotics, and the question that Parag has posed is basically, do robotics work? The answer is yes. Okay. However, what I thought I'd share with you in this presentation is my journey with knee arthroplasty over the past 25 years. It's been an interesting journey, and it also allows me to share with you how I've transitioned from different instrument platforms, different implant platforms, to give you some insight possibly into you as a young orthopedic surgeon, or even someone who's in an early established practice, that what you're doing now is not necessarily what you'll be doing in 20 years or 25 years. If you are in a young practice, you will enjoy transitions over the next 2 decades, which will see you in a different place, doing a different implant, using a different instrument platform, and that is a very exciting journey. Nothing stays still forever. Everything does move forward, and by sharing this with you, I'll at least let you have some insight, hopefully, into what may possibly happen in the future. I'm just seeing if we can, here we go. Before we start this, just my declarations, and I only put this up because obviously we're talking about robotics, and I do have some declarations you need to be aware of, particularly some educational consultancy with Zimmer Biomet, and I'm currently the Chief Medical Advisor Asia Pacific for Zimmer Biomet, and the robot that I will be discussing later in this presentation happens to be the one from Zimmer Biomet, so just to make you aware of that. Okay, so in short and in the capsule, my experience. Conventional instrumentation since 1996, which is really when I started practice as a consultant in my own right. I was using the cemented PFC, transitioned to cementless TKA with a dual fixed tibial tray within a few years. The sign navigation was introduced and I started using that in the noughties, as they call it, for a few years. I then transitioned to the signature patient-specific instrumentation. Once it was established in Australia in 2009, we were early uptakers, one of the first, and it became the mainstay of my practice for nearly 10 years using the Vanguard total knee replacement at that stage. I subsequently transitioned to robotic TKA in late 2019. December was the first procedure with the robot that I used. That was the ROSA robot. We've performed now over 170 ROSA robotic TKAs using the Persona total knee arthroplasty as the implant platform, all of which have been cementless. During this presentation, I'm going to share with you the transition as we went from one to the other, why, the benefits, the downsides, and hopefully give you some insight into how my practice has gone over 25 years and what you may anticipate. But everything is based on this principle. But the aims of any arthroplasty surgery, regardless of the technique and philosophy, is to implant the prosthesis in the correct position, then allow the chosen alignment, whatever that may be, mechanical alignment, kinematic, adjusted kinematic, individualized, whichever you may choose, along with soft tissue balance to result in a successful outcome. I'm going to start by introducing a case. I've called it the Knee Conundrum. And you may be wondering, if this is a presentation on knees, why I'm showing an X-ray of a pelvis, but you know, one is connected to the other. This was a 64-year-old gentleman. He had a left hip replacement that I performed. It was an EABG2 cementless, 16 years prior in 2004. I then did a right hip replacement. In that circumstance in 2009, I put an ABG2 femoral component, but in that circumstance, I used a modular neck, which was very, it was new and it was popular at that time because it allowed you the ability to account for more coxavera or coxavalga as it presented and have a better soft tissue platform. The Trident modular neck system, it was called back then. He had good function for many, many, many years without any problems. He worked as a mechanic, he was a laborer, he lifted heavy things, and it wasn't a problem until December 2018. He presented with acute right groin pain, fever, and a raised CRP. We aspirated his hip joint. 200 mils of fluid, parallel fluid, was evacuated from iliopsoas bursa. Cultures, they grew some strep miliary. Initial thought is this was an infection, and a hip lavage with exchange of the femoral head and liner was performed. The modular neck was left in situ, wasn't removed. But this gentleman continued to have problems, and here's an MRI scan. And what is notable here is the extensive amount of amorphous material around the proximal aspect of the femur, the posterior aspect of the hip joint. This amorphous material is akin to the sort of material you would see with metal changes. So he had a modular neck. Essentially, he developed a taperosis and a metal problem with an allergic reaction. And the sciatic nerve, which is arrowed here, has become involved in that whole extensive process that he developed prior to a two-stage revision that was being planned, an acute sciatic nerve palsy with a perineal component being lost, and he developed a foot drop. It was decided then to do a two-stage revision to remove the implants. Histopathology confirmed a lymphocytic reaction. Infection was not the cause for his failure. There was no further pus or fluid collection. We did a two-stage revision. That whole process has been over the past 1.5 to 2 years. The reason I present him is throughout all of this, when he presented with his hip problem, he also had a knee problem on that same side. He had a severe valgus deformity of the knee. He had a stiff knee. You can see the marked osteophytes both anteriorly and posteriorly. He had difficulty ambulating. This is also the side that he has a foot drop. So here we have a gentleman who's got severe problems with his knee. He's got revision hip surgery that's occurred over a period of 1 year. One initially thought to be sepsis, then thought to be a reaction to metal implants. And then he's in the middle of a COVID-19 pandemic. So the decision-making process of when to intervene for his knee and how to intervene is part of the problem. So I'm going to leave it at that, and I'll come back to this case at the end. But it'd be interesting for you to go through a process of when you would intervene once you've resolved his hip problem, and how you'd approach this severe fixed deformity, valgus deformity, with lack of flexion, in correcting his deformity and giving him some sort of a functioning knee joint. So successful total knee requires a number of things. It needs appropriate component sizing. Component alignment has to be correct, and that's worthy of extensive discussion. Soft tissue balancing has to be secured, and now more than ever, we need to discuss that, particularly with the introduction of robotics. Patella has to track centrally, and the components have to be fixed for longevity. And that can introduce the argument of whether you use cement or non-cement. That isn't the gambit of this presentation. That's worthy of another presentation on its own. Suffice to say, I do use predominantly cementless fixation, but I've put that in as part of the algorithm that you need to decide on in selecting your implants. So you may well ask, why did I use PFC Sigma when I first started practice in 1996? I was fortunate enough after my training in Sydney to attend fellowships. I did 2 fellowships. The first one was in Phoenix, Arizona, and the second one was in Boston, Massachusetts. And of course, my exposure there, being a J&J fellowship, was to the PFC knee. And certainly in Boston, I got to work with the designers of the PFC knee. So it was fairly straightforward that after that sort of exposure over well over a year, I'd come back doing the PFC. And that I did for a good 12 years of my initial practice. And the reason is that it was an implant that was sound, it was an implant that worked, and it was really me trying to make sure that I was using an implant that wouldn't get me into trouble in the first formative years of my practice, because the last thing you want when you start is to have complications, because then the word gets out and there's a concern about your practice. So you want to use a well, true and tried implant platform. You want to use appropriate fixation, and you want to use appropriate instrument platforms that ensure they optimize the outcomes for your patient. The sort of things we were considering back then is appropriate component sizing. Pre-operative templating was a standard for all patients back then, with those templates placed on analog x-rays, which were available at the time at about 115% or 120% magnification. The concern was if you undersize the tibia, you may end up with subsidence of the implant. If you oversized it, you'd end up with soft tissue impingement. So you've got to get that sizing correct. The femoral component, if you undersized it, you could end up notching the femur, or you could end up with a loose flexion space and mid-flexion instability. If you oversized it, you had a decreased range of motion due to overstuffing, particularly in the anterior compartment, and you could end up with soft tissue component impingement. Here's a case of windswept knees that went on to have appropriate total knee arthroplasties using the PFC. You'll see here at the beginning of my practice, certainly a component of my patients ended up with the PS, but overall, my practice is predominantly 80 to 85% CR. In terms of fixation, the femoral component, you consider whether you use cement or cementless, same with the tibial component, and you may be an all cement, you may be all cementless, or you may be a hybrid, predominantly with the femoral component being cementless. I started out cementing all components. I quickly transitioned to hybrid fixation, and then the DuoFix tibial tray based on the AMK and later modified for the PFC was predominantly designed in Australia. It had a porous HA coating, was a very good surface preparation for cementless fixation, and I started using that. Now I have 20 years of experience with the DuoFix tray. It's no longer on the market to share that with you, but this is one of the cases that was performed a long time ago, and now we have 20-year follow-up. And one of the beauties of cementless fixation, if you have good surface preparation, and there is differences between the tibial trays, is that interface between the bone and the implant remains pristine even 2 decades later. Standard conventional instrumentation. There's absolutely nothing wrong with it. I used it for a long time. You will recognize all these instruments. Many of you are using these instruments. They still remain arguably the gold standard by which all measurements are made. Tibial alignment, the lower assembly, lies over the malleoli to find the midpoint of the ankle joint. You'll then distract that. So every 6 millimeters is 1 degree. You've got to decide, depending on the mechanics of the implants that you're selecting, whether you're building in 3 degrees, 5 degrees, or 7 degrees of posterior slope, or if you're using PS, certainly you're not going to add too much posterior slope. You'll go for 0, 1, or 2 degrees. That will be a decision you make, but you have these conventional instrumentation that allows you to reproduce that in a reasonably reproducible fashion. Mediolateral translation, basically you'll line that along the tibial crest to ensure that the coronal plane of your tibial component is somewhat centered, particularly if you're aiming for the tibial component to be perpendicular along axis of the tibia. You then take your measurements off the tibial surface, 8 millimeters from the high side, 2 millimeters from the low side, depending on whether you're in varus or valgus. You pin it, you make your cuts, you remove your tibial osteotomy, you size your tibia correctly, and you finish the preparation of the tibia. On the femoral side, again, you're all familiar with this. The 3-foot film, I used to do routinely for the first 5 years of my practice. I used to measure religiously the mechanical axis and the anatomical axis of the femur, whether it was 4 degrees, 5 degrees, 6 degrees, or 7 degrees. I'd then reproduce that with the femoral cutting from the intramedullary rod, and then you'd basically reflect whatever the patient's femoral valgus angle is and make sure you make that cut so the femoral component is directly perpendicular. So you can get a gist that what we're aiming for in the first part of my practice was principally to ensure that I was doing a measured resection technique with the implants being perpendicular to the mechanical axis for every single case. Once you've made the distal femoral cut, you then made sure that you had a quadrilateral space. You used your extension spacer block to make sure the fit was correct. You'd reduce the patella, and then you'd lift the leg really to see, have you achieved full extension? And if you have, you're fine. But this is the surgeon, this is the art of surgery. The surgeon would stand back and say, yep, that looks like full extension to me, or maybe that's about 5 degrees. But was it really? We had no means of actually measuring it, except when we looked at the x-rays and the post-operative film and saw the patient once we took all the drapes away. And of course, the bigger the patient, the more sizable the girth, then the harder it is to actually make that estimate and get it correct. But this is the technique we used. Some still use it today. Now, of course, we have more modern ways of determining what those angles are, and this is the ethos of this presentation leading up to the transition to robotics. The other thing we did religiously, I used to mark this out on every single patient. That is the transepicondylar axis, from the sulcus of the medial epicondyle to the most prominent point of the lateral epicondyle. Mark it out and ensure religiously that the femoral component is rotated to match this line in every single patient. You'd spend a little bit of time making sure you got the lines right, or that your registrar got the lines right, and reproduce it, arguing always that this is the correct way to arrange the femoral component so you ensure patellofemoral tracking is correct, and also to make sure that in a valgus where you've got a hypoplastic lateral femoral condyle, you're not completely relying on the posterior condylar axis. So the measured resection and rotation to the transepicondylar axis, rather unique. Why did we do this? Look, there were lots of presentations, and this is one of them. Scott and Thornhill, my mentors from Boston, Massachusetts. They were designers. They were certainly prolific publishers as well. And here we have a minimum 10-year follow-up using the PFC knee system, 92% overall survivorship. Implant survivorship was 100%. And at the end of the day, if you're a young surgeon and you're in the early parts of your practice, you want to select the technique, you want to select an implant that delivers. And this certainly seemed to deliver, so there's no reason not to use it to follow that technique. So what changes over time? Well, things are introduced. Modern things come into being. Navigation systems came along in the noughties. They provided surgical information systems where the surgeon controls the intervention and performs the surgical action. That was the heralding cry. The problem was it was expensive. As with any new technology, there's a cost associated with it. Now, back then, this looked like quite a substantial cost because when compared to current robotics, it's a lot less. But at the time, this was a considerable cost. The other problem is it's usually a closed platform software. So it's implant specific, it's company specific. Nevertheless, they were available and computer-assisted surgery came into being. It offered greater accuracy, and if we were after delivering an outcome to the patient that improved their well-being, you wanted to make sure that what you're aiming for is what you achieve for every patient, not just 90% of them or 95% of them. These were based on a number of different systems. One was CT-based, others were fluoroscopy-based, but the one I used was the image-free, which means we didn't need any pre-operative imaging, but you spent a lot of time mapping out the landmarks at the time of surgery. 3 steps to navigation. There was data acquisition, there was tracking, and there was registration. You required the hardware, which consisted of the camera, the computer, the arrays and trackers, and this instrument platform that went with that. This seemed like a good system at the time in delivering greater accuracy and was certainly well worth the trial. Some of you may well be familiar with the early versions of navigation as they presented that allowed you to look at the femoral flexion angle. You can see here the flexion space medially and laterally. For the first time, it gave you a digital readout of what we were actually seeing using conventional instrumentation. This was exciting at the time, and it seemed to deliver greater accuracy in our hands. It allows bone morphing with better landmarking, but for the first time, something was introduced into the operating theatre that seemed to interfere with the way and the normal flow of what we would actually do. So you can see here the setup for me with the camera on one side, opposite where I was standing. The assistant had to be out of the way. The computer screen was close, it was a touch screen. You were able to manipulate that during the surgery. The landmarking, basically you had to establish for the computer where the tibial plateau was medially and laterally, the anterior surface of the tibia, the medial lateral femoral condyles, the anterior surface of the femur, and from that, the computer would then go to work and create smart instruments so that every instrument that you normally had in terms of smart blocks, if you add an array to it, then it knew where it was in space. One of the difficulties, however, is that you had to manipulate that, and it really came down to the dexterity of the surgeon to be able to manipulate those blocks into a position until the line went blue or green, depending on the system, and then you pinned it in place, hopefully within a degree or a millimeter of accuracy. It did slow the process down a little bit, but all with the intent of delivering good accuracy that made a substantial difference from conventional instrumentation. One way of measuring those outcomes was the CT Perth protocol, which we started to use routinely for every case. This allowed you, using CT long films, to actually measure the coronal position of the femoral tibial components the sagittal position of the femoral tibial components, and importantly, the only way you can measure the rotational position of the femoral component. We started by doing a learning curve to see if the introduction of navigation or computer-assisted surgery was going to slow us down substantially or lead to errors which we weren't anticipating. And we compared computer-assisted knee arthroplasty to the jig, and we found, as you can see here, by measuring femoral rotation, flexion, tibial valgus, so basically the coronal and sagittal position as well as the rotation of each component, that with our learning curve of the first 20 patients, it didn't make a substantial difference. We certainly weren't finding errors, so this was worth pursuing further and doing a proper trial to see how much of a benefit this provided to our patients. The success in knee arthroplasty is to get correct implant alignment and to ensure good soft tissue balancing. The hope was by ensuring implant alignment was correct, soft tissue balancing would follow. TKA, computer-assisted surgery, may therefore become the instrument by which we can ensure that we achieve this more often than not. And I put a big question mark on there because the question is, where are we going to end up from there? So we commenced a randomized study, randomized control navigation study, 3 surgeons, 150 patients. We randomized to psi navigation versus conventional instrumentation. We used the PFC, fixed and mobile TKAs. CTs were performed routinely at 6 weeks and a clinical assessment by physio at 12 weeks. This is to show you that no matter by randomizing, whether we use jigged or psi navigation, whether it was left or right knee, it was about the same for both. Whether it was CRPS, there was really no difference. Fixed or mobile, cemented or uncemented for tibia and femoral components, it was even across the park there for both components. So some of our results, what we found is the duration of surgery was certainly longer with the navigation. There was no question about that, and that was significant. But blood loss, similar for both. There was no difference in blood loss between the two, even though we didn't instrument the medullary canal. Post-op hemoglobin level was the same for both. Duration of stay was no different between either. So the only difference identified so far was it took longer to do the navigated total knee arthroplasty. We measured knee scores pre-op and post-op, as well as function scores pre-op and post-op, and again found little difference. Then we did the difference in score, that is from the post-op score, we took away the pre-op score. This provides a more accurate representation of the changes resulting from surgery. And we found basically for the knee score, no significant difference between the two procedures. And with the function score, again, no significant difference between the two procedures. So in fact, we'd introduced technology, but at this point in time, we haven't actually identified a significant improvement in the patient's outcomes using PROM scores. We measured the CT data, and this started to show a little bit of difference in that you can see here the femoral rotation, femoral component rotation. There was a significant difference between the two, with the navigated being more accurate, and the posterior tibial slope, that's the sagittal position of the tibial component, was more accurate with the navigated component. All the other components that we measured, there was no difference between the two. And this is to show you in a graphical representation the femoral component rotation. Although it looks across the board to be similar, it was found to be significantly different and improved with navigation. But for femoral flexion, which is a sagittal profile, there was no difference. Femoral coronal profile, there was no difference. Tibial coronal profile, there was no difference. The posterior slope, there was a difference, the sagittal profile of the tibial component. So our interim results showed no significant difference between either for the knee scores or the function score. There was a significant difference in duration of surgery between jigged and navigated, with a jig system conventional taking 21 minutes less than the navigated technique. And there are correlations between the duration of surgery and the procedure. The jig technique has shorter surgery time, and older patients have shorter surgery time. And if there was some benefit to the navigated technique, it was that the femoral rotation was more accurate, and posterior tibial slope was more accurate. So we identified that there was a benefit there, but we were concerned about the fact that it took an extra 20 minutes or more to do navigation. And I must say, over time, navigation for us kind of died out, particularly for what we call the fiddle factor. That is the fact that you could get those cutting blocks in a position, but it often took a little bit of time to ensure accuracy. and often you had to compromise and accept a millimeter off or a degree off from what you were actually aiming for. So in 2009, after looking for something that could potentially be less time consuming and more accurate, patient-specific instrumentation in the form of the signature guides was introduced with a Vanguard total knee arthroplasty. And to me, I thought this was a really good concept. I liked the idea. No pins, no risk of fractures, no risk of pin site infection, no instrumenting of the medullary canals, no computer at all in the operative field. Go back to having your assistant stand wherever they want to stand. All planning was done pre-operatively with none intraoperatively while the patient was under anesthesia. The implant size options were pre-selected, so you didn't need the full range from 1 to 8 of every femoral component. You only needed the size that was pre-selected plus a size up or down potentially. Reduced instrumentation, improved setup times by about 17 minutes, and this was measured. And all planning is based on MRI for accuracy of landmarking. And here's an example of a patient that I would have with a varus deformity. We would do their pre-operative MRI scans. We'd get the plans projected to us. We'd be able to manipulate the plans. We know the level of deformity they have beforehand. We'd select the implants. We'd look at the balance, both in flexion and extension, approve the plan. Eventually, these patient-specific instruments would be sent to us. The whole period would take about 4 to 5 weeks. Then at the time of surgery, this is all the instruments that you need. It's a very simple set of 2 trays that you open, and saves a lot of time in preparing for the patient. Scrub sisters are really happy with it. This is on a little bit of fast track just to show you the tibial PSI that I was using for about 10 years would fit on very nicely. We'd have a drop rod for visual line of sight confirmation. We'd pin this in sight. Once it's in, we'd use a standard cutting block, cut through that to remove the tibial biscuit. The femoral PSI would similarly sit straight onto the femur. This was quite accurate. It'd be pins in situ. Once the pins are placed in, the PSI guide is removed, and again, the standard cutting block is used to make the distal femoral cut. Again, the transepicondylar axis is drawn just for comparison, but you've already made that decision using the PSI guides and the MRI scan preoperative planning. The 4-in-1 cutting block is placed on. This is cut. This is again an approach for measured resection technique, and then you make the soft tissue releases as required after the reduction of the trial components. This was a satisfactory technique for implant alignment with overall good outcomes. This is a cementless Vanguard that I used for a decade. A good cement bone interface was seen in all these patients, and there were no exclusions to these patients. This was in all comers. We reported on our first experience of 261 patients with the signature patient-specific guides. The alignment of the implants within 3 degrees, and the coronal plane for the femoral component was 99%. Our coronal tibial component was 92%. Rotation of the femoral component was very high, accuracy of 96%, and the mechanical axis we were hoping would be in excess of 90%, which is what we expected with navigation, particularly computer-assisted navigation. But here with the patient-specific guides, it was more in the vicinity of 80%. They then went to new online planning software. It looked different. It felt a little bit different. It had some new nuances, but gave us a little bit more flexibility in preoperative planning. We continued to use this, and then we looked at our 700 knee replacements using this, reported on the first 500 that had good outcomes, 305 females, 195 males. There's the age groups. You can see they were in all comers up to the age of 90. All my patients, total knee surgery between 2009 to 2015, all using cementless TKA. Again, CT Perth protocol was performed on all these patients to assess the implant positioning, as we strongly believed that getting the implant position right would dictate a better outcome. You can see here the femoral component in terms of coronal positioning was 94%. There were outliers both in varus and valgus, but very small outliers here. The femoral component to the transepicondylar axis, this is rotation, 90%, with some outliers both in external rotation, excessive, or internal rotation. The tibial component, Again, 90% with some outliers in varus and valgus. And overall mechanical access was 82.4% in this large group, with some outliers. Most of our outliers in this circumstance were in valgus, if they're going to be outliers, not in varus, interestingly. The thing, of course, is we focus so much on numbers that you can see a patient like this who comes for their post-operative visit. You take a look at them, you think, wow, this looks good. They walk, they have no pain, they have good range of motion, good flexion. But then you measure their numbers, they're in 4 degrees of valgus. So this would actually present as an outlier and question your technique, even though the patient was very happy. So sometimes you can get so focused on following patients up, you can actually sometimes do yourself a disservice, but it's all in actually collecting data and having an idea of how you're implanting these implants in these patients. So how critical is it really for these outliers as they appear to be happy and functioning well? Can we detect a difference on outcome measures? Now, you would be aware of one of the landmark papers by Sebastian Perrat, Truesdale, and Dan Berry, and this reviewed 398 total knee replacements retrospectively for a 15-year Kaplan-Meier survivorship from the Mayo Clinic. 73% of total knee replacements were mechanically aligned within that elusive 0 plus or minus 3 degrees. Only in the frontal plane were these x-rays taken. 27% were considered outliers, but again, I emphasize it was only the frontal plane or coronal plane that was measured. Of this group, total revisions, 15% in the aligned group. This is a group that was thought to be in excellent position, should have a better outcome, whereas in the outlier group that should have had the worst outcome, their revision rate was only 13%. Aseptic loosening with mechanical failure or wear was 5.8% in the aligned group, only 3.8% in the revised. So the questions were raised. If we're aiming to get all these patients perfectly aligned, we expect better outcomes. But this paper threw into perspective that maybe we're not actually looking at the correct means of assessing a successful knee replacement. So with a colleague of mine, Yasser Khatib, I decided we'd review our own series and see if we could actually predict a better outcome for patients. We didn't have the long follow-up, but we looked at 444 patients with PSI TKA. At 6 years, they had a revision rate of 1.9% in all comers. So that was small. But our series divided them. They were all cementless TKAs. And we took a look at their range of motion. There's their preoperative deformity was from 21 degrees of varus up to 17 degrees of valgus. So they had all comers in this group. We also had all comers in terms of BMI. There was no exclusions here. We just wanted to see if we got our patients within the desired mechanical alignment, do we have a better outcome for these patients? Does neutral mechanical alignment plus or minus 3 degrees affect post-operative outcome? We found no difference in the post-operative scores, whether you're an outlier or whether you're well aligned for the WOMAC, AKS, knee score, function score, or range of motion. Does more accurate alignment, that is, if we measured, and we did, for those that were within the range of plus or minus 1 degree, does it affect post-operative outcome? And again, we found no difference. Does post-operative alignment affect post-operative outcome? If your post-operative deformity is within 3 degrees, no difference. So achieving good outcomes after knee is more than simply restoring neutral mechanical alignment or achieving perfect component orientation. So can we do better? Need more intraoperative information on prosthesis positioning, need intraoperative feedback on the soft tissue envelope and flexion extension balance. And the question was, how can we achieve more information during the surgery that's more accurate, more validated, more feedback for the surgeon to be able to manipulate at the time of surgery the patient's outcome? Is robotics the answer? It became available. The question was, should I consider it? And I really didn't hesitate because I thought we need to go one more step. So let me introduce robotics and the options. They can be fully active robots, semi-active, with or without haptics, and that's where most of the robots you will be exposed to actually are. And then there's passive robots. And most of the robots on the market, obviously I use the ROSA, but let me introduce you to Omnibot. So this is the Omnibiotics. So this is the balance bot. and the Omnibot robot here. These are smaller robots, don't take the same real estate or footprint like the Rosa or the Mako. Mako is obviously the first robot on the market. It's been around now for about 7 years. Rosa's been around for about 2.5 years. Omnibot's been around for about 3 years. The Navio you're familiar with now, it's called the Corey. That's the new Smith & Nephew robot that's coming out. And there's a couple more on the market besides these. The benefits are they give you direct feedback with the cuts and implant position. They give you direct feedback about limb alignment, direct feedback about range of motion, which is actually measured in a digital format that you can read off and not guess. And there's a digital expression of the soft tissue envelope and the balance of the soft tissues that can vary from robot to robot. But the best thing about all of these is that it'll give you the estimate of what is required to achieve balance. And then once you've made the cut, it will validate that cut for you. So you know there and then if that cut is accurate or whether you've made an error, and gives you the opportunity to go back and correct that if you choose to. You may not choose to, you may accept it, but at least you as a surgeon have the choice of going back and correcting that by a degree or two or a millimeter or two, whatever it takes to end up with the result that you actually set out to achieve in the first place. And for the first time, you have a means of actually detecting that and correcting it. So the benefits are you set the preoperative alignment targets, visually restore and validate at time of surgery. You adjust the soft tissue balance with a flexion gap balancing tool, which I've started using on a regular basis to titrate the soft tissue releases only as needed. This has changed my whole approach to total knee arthroplasty, and it's actually improved my early outcomes for my patients. To look at the robot that I use uses standardized plain x-rays, and you can go imageless if desired, but at least if the imaging is required, it's plain x-rays that are done following a protocol as opposed to the PSI, which required MRI or CT. Some of the robots also need CT routinely, but the one I use uses plain x-rays. There are no guides to manufacture, so the turnaround time is within a week, everything is ready to go. There's no delays in booking patients, and the surgical approval can be done either preoperatively or at the time of surgery itself, whereas the PSI guides all need to be done with an approval approximately 4 weeks before, unless you have your own 3D printer and you're printing it at home. The approach no longer requires any medial or lateral releases on initial exposure. All I do on the exposure is simply a straightforward medial parapatellar approach, really to expose the knee. I don't do any medial releases. I don't go around the posterior medial corner. Even in a severe valgus, I don't do any significant lateral releases at all at the beginning. I do it after the cuts are made and the robot is used to help balance. And it's only then you may titrate some minor releases if required, but to be honest, we found that releasing has become really a minimal thing that we do not do, as opposed to my routine technique with conventional instruments. I no longer translate the tibia anteriorly on the femur as part of the first exposure, which I used to do. The tibia is cut first, then the distal femur. The flexion balance is now optimized with this balance tool called the fusion device, where I religiously drew the trans-epicondylar axis before. Now I actually landmark the epicondylar axis, but no longer draw it, no longer look at it, because I use a balance tool to completely dictate femoral rotation to optimize flexion balance without having to do releases. I'm going to share with you the first steps here for robotics is to obviously put in the femoral array. The femoral array has to be pointing towards the camera. You can see here the robot is standing on my left-hand side. I always place the robot on the right-hand side of the patient. Doesn't matter whether I'm doing a right knee or a left knee, I'll stand on the same side as the patient's knee that is being operated on, but the robot with a robotic arm will always stay on the right-hand side. The arrays are put in the femur, secured into position, then the tibial array is placed on the tibia. Of course, all arrays have to be adjusted so that they are pointing towards the camera, which is on the opposite side to the robotic arm. This means that between the arrays and the camera, you've got to be careful where your assistant is. So it does, again, dictate the positioning of your assistant and how they come in to help you, because you've got to keep that line of sight nice and clear. Putting in the arrays really takes a couple of minutes. This is in real time as you see it go in. You basically use a 3mm pin. I put all pins and arrays within the incision, not outside the incision, so it's in metaphyseal bone, decreasing the risk of pin site fractures or pin site complications. Once you've put in the arrays, we start the registration process. You can see here the robotic arm will move through approximately 6 positions, thereby establishing its position on the floor in relationship to the patient. Once it does its 6 position movements, it is then locked and ready to go. And the array, which you can see here on the robotic arm, is then exchanged for a cutting block that then is brought into position to help you cut the distal femur and the proximal tibia. This process takes about 90 seconds in order to register. Now the arm is registered. We go through a process of landmarking for the center of the femoral head, canal entry points, the posterior condyles, white sides line, transepicondylar axis, the posterior condylar line, and the anterior cortex to ensure no notching. We also mark out the malleoli, so we know the mechanical axis of the limb, and then positioning for the tibia. You'll see here how we go through that process. My assistant here is changing the array for the cutting block. I'm going through the 14 points that are collected for the center of the femoral head, so it's the top of mechanical alignment. Again, it's a quick process. It makes a noise every time that you stop in one position, collects that data. Once you've gone through that process, we then invert the patella, we take it up into flexion, and we start landmarking with a pointer for the entry hole for the intramedullary canal. We then use a universal guide that sits under the posterior condyles. That measures the posterior condylar axis and introduces that into the robotic algorithm. We then use the pointer again, taking the base of the highest point of the notch and the lowest point for white sides line. We then feel for the medial epicondyle and go to the sulcus of the epicondyle. We feel for the map out the distal part of the femoral condyle with 3 points. We go to the lateral epicondyle. So now the transepicondylar axis is registered. We go for the most distal part of the lateral femoral condyle to map that out. Once that's completed, we go to the anterior cortex. We put 3 points of registration here to ensure no notching. And this is important to gauge also the sizing of the femoral component anterior to posterior. Once that's collected, the femoral landmarking is complete. We then mark out the medial malleolus and the lateral malleolus, which then defines the mechanical axis of that limb. We then mark out landmarking the anterior aspect of the tibia over the tuberosity for rotation of the tibial component, the medullary axis of the tibia, the PCL line, and then we mark out the lowest point, which is basically where you would put your stylus for the medial tibial plateau and the lateral tibial plateau. This whole process, as you can see, took about 4 minutes to 4.5 minutes. That's the registration process. It doesn't take that much. It adds a little bit of time, but probably saves you time in the long run. Once you've manipulated the robotic software, you're then ready to make your first cut. The robot, as you can see then, there's no, one of the downsides of navigation is trying to move that block and get it into the right position. Here, that work is done for you automatically, and then with collaborative mode, you move the tibial cutting block onto the tibia, you place the pins. You can use 1, 2, or 3. I, as a rule, use 3 pins, and that locks it onto the tibia. And then once that's in place, you're ready to make your cut. Using a standard saw, you make your tibial osteotomy and remove the tibial component. We're then ready to do the femoral side. And I do the tibia first, but you can do either first, but I find as a routine, tibia first works for me. Again, the robot goes through 2 movements on its own, and then collaborative movement down to bone for safety. You adjust it in the right position. It will remain in the same plane no matter where the leg is. Pin it to the leg so it doesn't make any movements. Of course, what I'm not showing you here, but I will later, is you're validating everything to make sure that the position is exactly what you predicted. Once that's in place, you then go through and cut your distal femur. Note that you do have to change the way you actually cut. simply because of the presence of the robot and your assistance on the other side. Once you've done that, you can see you're validating the predicted cuts, the cuts you've actually achieved. Make sure they're close. It doesn't have to be perfect, but within 0.5 millimeter or 0.5 degree. You've planned 3 degrees of flexion, you've achieved 3 degrees of flexion. So it actually validates what you've done there and then. If you'd planned for 10 and only cut 8, you then got the choice of going back, cutting another 2 for whatever reason, it wasn't an accurate enough cut. This is the fusion device. So this is what is placed in extension and then brought to 90 degrees of flexion. It's then dialed up with a screwdriver to tension both the medial and lateral sides, and this will dictate the rotation of your femoral component. Once it's in the right position, the algorithm is then fed into the computer, and you have at that time the ability to move the tibial and femoral components into a position that at the end achieves a better balance for your knee. Now, we don't have the time here to show you everything. However, you can see here, this is not balanced. The medial side flexion space is 18.5, whereas on the lateral side it's 23. The extension space is 20, and on the lateral side it's 21. But through a process being able to manipulate that, you can end up, and you can manipulate the femoral component, the tibial component, you can end up with a balance that may equate something a little bit close to what you expected, so that you have a flexion space that is 19 to 20 millimeters on both sides, and an extension space that's 19 to 20 millimeters on both sides. Why 19? Because that's the minimum requirement to get your implants in. So you have that facility to change that. Once you've determined the rotational position, this is the final time that the robot comes into position. Again, with a collaborative mode onto the cut distal surface, you then put your 2 pins in, and this is the pins that will define where the 4-in-1 block goes, and it goes into that position, already dictating the rotation of the final seating of your femoral component. Once you've cut using the 4-in-1 block, you're then ready to do a trial. Once you do the trial, again, you check with your computer that the balance is correct. Do you need to do any soft tissue releases? More often than not, you don't. However, in very severe varus or valgus greater than 20 degrees, you may need to do. And at that point, after removing the posterior osteophytes, you would then come in and do whatever releases are required, but it will be a lot less than what you used to do prior to this because of the optimized positioning of your implants. You're then ready to put your implants in. I happen to be using the cementless Persona tibial component here and the cementless Persona femoral component. These are punched into position. You can see how a good hold it is initially. It's tapped home. Polyethylene component is then placed on that. A little trigger device pushes it home and secures its fixation to the tibial base plate. I use a CR in approximately 80 to 85% of my patients. A remainer will get a medial constrained knee. I don't use a PS anymore, and I never cut a PS box anymore. Again, the cementless femoral component is then taken home, getting a secure fit in these patients. And then once in, you can do a final reduction and again, check on the computer that you've achieved the desired outcome in terms of extension, range deflection, and balance. So the use of the arrays are some concerns for the femur and the tibia, but in over 170 cases, I've not had any fractures or other complications to date. Hopefully I won't, but I will describe problems with pin site problems, as you'd well be aware, and the worst complication would be a femoral fracture after a navigated case. The cost is another issue. Cost can vary anything from $500 for the smaller robots per case up to $1 million for a big robot as a one-off payment. These are ongoing costs for the patient as well in terms of use, but cost factor has to be taken into consideration. Back to the case example that I gave at the beginning, this patient had a very valgus knee. You can see here The question was when. Well, obviously I waited a whole year after his hip replacement to make sure he didn't have a septic process, that everything settled, that he had a good outcome. There was no recovery to his foot drop. It remained a problem for him. I proceeded with a knee replacement using robotic technique. You can see his pre-operative assessment here showed that he had a 28-degree fixed valgus deformity. We ended up using ROSA, and this is his day one post-op, sitting up in bed. This is more flexion than he's had for over 2 years now. He's got a VAC device Provena dressing on, and he's got his total knee replacement in place. We did a small fenestrated release of the posterolateral corner as part of his correction, but he achieved good correction. And you can see the balance through the range of motion here from 0 degrees or full extension to 90 degrees to beyond, where his balance remains almost neutral throughout for someone who had a fixed 28-degree valgus deformity. So patients are more comfortable in the first 48 hours. They achieve flexion to 90 degrees in the first 24 hours. Improved sagittal alignment to the femoral and tibial components was noted. I compared the last 67 persona cementless TKAs that I performed using PSI technique to the very first 80 persona cementless TKAs using ROSA robot assisted technique, which was my learning curve. All had the CT Perth protocol at 6 weeks. What I want to share with you here is of interest. The femoral component using ROSA in the sagittal profile, that is femoral component flexion and tibial slope, was much more accurate using the ROSA robot compared to my PSI technique. So that was pleasing to see, and you can see how it's much tighter here in the green line for the robotic technique as compared to the PSI technique. As far as the other parameters, they were all similar. Femoral coronal alignment was 94% to 96%. Tibial coronal was similar, and mechanical access was greater than PSI. So in conclusion, transitioning from PSI to robotic assist TKA has been a reasonably straightforward adjustment with a very small learning curve, allows significant changes in technique to be made with confidence to the benefit of patients and improved outcomes in the form of earlier mobility and knee flexion and improved sagittal alignment of the components. This has been my transition over the last 25 years. What does the future hold, particularly over the next 10 years? Well, each of those robotic techniques collects a mountain of data, which is provided to you on a USB stick or by email after, but it's also kept by the company. This is metadata that will be collated over a number of years for numerous patients globally, from varus to significant valgus deformities, and I suspect somewhere in the next 10 years, the robotic arm will become automated to provide solutions to soft tissue balancing for each type of scenario that's typed in preoperatively for each patient, thereby making us maybe just technicians in the journey. Who knows? But it's an exciting time to be part of, and I hope you've enjoyed this presentation. Thank you for your attention.